Now we can introduce Professor Richard Fessler. I'm sure that most of you know him very well. He's one of the pioneers in minimally invasive surgery, and he will talk on the tube-guided surgery. Yes, Professor Fessler.
All right, are you able to see my screen?
Yes.
Excellent. So this morning I thought I would talk about doing minimally invasive intradural tumor resection. These are my, my disclosures, none of which have anything to do with this. Now, when doing minimally invasive surgery, the principles are the same as they are in open surgery when we're approaching tumors. We want our laminotomy or our laminectomy to include the full extent of the tumor so we can get both cephalad and caudal control. We want to make our laminectomy wide, particularly ipsilateral to the tumor so that we can get a good, safe approach. And if we're doing a dural-based resection of a meningioma, we can remove the dura and replace it just as we can with open surgery. At the same time, we want to preserve the vertebral body and the ligamentous structures. We want to enable reconstruction of the spine and the dura. We want to preserve the nerve roots and the arterial supply. And we want to preserve the mid and low dorsal roots in the cervical spine, because if we take the dorsal roots, even if we have motor roots, the limb becomes functionless. So for example, this was a gentleman who works for the telephone company, and he's the guy who climbs up the pole to run the wires from one telephone pole to the next. And he began to note that he was losing his balance and was uncertain when he was climbing up ladders, and came in for evaluation, and we found this large intradural tumor. Typically, years ago, the operation I would have performed would have involved a multi-level laminectomy, a wide exposure of the tumor, and then posterior reconstruction to avoid swan neck deformity. But instead, we did a minimally invasive procedure for him, where you can see this was our entire exposure. This was the preoperative sagittal image of the tumor and the axial image. And postoperatively, you can see we got a complete resection of the tumor. Because we did it minimally invasively and not the way we traditionally would have done it, he was able to go back to work. Had I done this in the open technique that I used early in my career, he would never have returned to his kind of employment. So the question is, if we need to approach a tumor such as this, which is a ventrally located meningioma, do we really need that kind of an exposure with all of this exposure in order to get to that little tiny thing right there, to get ultimately a picture that looks like this? So the problems with open surgery are that it causes significant pain. We have increased blood loss. We resect all the posterior support structures, including the bone and the ligaments. It requires a prolonged recovery. Those muscles will never regain the strength that they had preoperatively. And in thoracic and cervical spine, we can develop kyphotic deformity, particularly in pediatric patients. So when we're approaching a tumor like this, do we really need that kind of an exposure, or can we approach it through that kind of an exposure? And in the sagittal view, do we need that exposure, or can we do it through this exposure? So initially, when I started these surgeries for tumors, I made my incision about 5 centimeters off. I was thinking I would need a very lateral approach in order to expose the spinal canal, but it turned out I was completely wrong. I now do my incision about 1.5 centimeters off midline, which enables me to drill off a significant portion of the ipsilateral base of the spinous process, and by doing so, expose the entire dorsal surface of the dura and spinal cord. So what we do is we mark our incision, we make it, we dilate down, and then after I do my ipsilateral laminotomy, I angle my tube and drill off the base of the spinous process and the ventral aspect of the lamina all the way over to the contralateral pedicle. So when we go through our decompression, ipsilaterally and contralaterally, we can expose the entire dorsal surface of the dura and the spinal cord underneath it through a little incision like that, about the size of a quarter. So this is my series. I've done quite a few intradural tumors and several intramedullary tumors, about equally divided between men and women, approximately 44 years of age, and with the typical presentation: pain, paresthesias, weakness, urinary urgency, and impotence. One patient was quadriplegic from a gunshot wound. The reason we actually took his bullet out was so that they could use it as evidence in the trial of the person who shot him. So let's see if I can play this video. There we go. So we've made an incision. In thoracic spine, I like to do a blunt dissection because the facets come up so high that if you do a standard dilation, you end up with a lot of muscle in the base that you have to resect. So I do a blunt dissection with my finger to get that muscle out of the way. And then I put in one of the larger dilators. For most of these tumors, I will use an expandable tubular cage. So here you can see that we've got the ipsilateral lamina and facet exposed. We're removing just a little bit of the soft tissue over it, and now drilling off the ipsilateral lamina and a bit of the ipsilateral facet. This image is coming from a camera in my headlight. Once I've got the dura exposed, we'll flip to a microscope. Now I'm drilling the ventral surface of the contralateral lamina to get all the way over to the contralateral pedicle. And because of the angle I'm coming in at, which is only 1.5 centimeters off midline, I'm essentially coming right down on the middle of the dura, and therefore the middle of the spinal cord, which is the location we want to be, so we can do an opening right between the dorsal columns. So now we're opening the dura. We've got a 4 neuron stitched through it so that we can retract the dural edge to the side. And you're beginning to see this. Here is the tumor. You can see it right there in the middle. This is a hemangioma. And now we're under the microscope, splitting the dorsal columns. And very gently spreading them apart. And you're beginning to see the tumor there, kind of purplish. So here we are, we're working on the caudal end. We're exposing the caudal end of the tumor. And we've now gone up to the cephalad end. So that just as we do in open surgery, we're isolating both ends of the tumor. And then we can slowly start separating it from the surrounding spinal cord tissue. Working our way back and forth around each of the sides. And then with a biopsy forceps, beginning to take it out. And then once it's out, we have make sure we've got good hemostasis within the cord. Explore to make sure we've got it all. And then close it up. So we've done a lot of these kind of tumors now. This is a called equine ependymoma. Postoperatively, you can see the exposure that we get. We get essentially a midline approach to these tumors. Here's another one, quite large, as you can see, right here. Completely able to resect that. It takes about 4 hours. We lose about 50 cc's of blood. About half of our patients went home within 24 hours, and almost all of them went home within 2 days. Of these 33 tumors I'm completely reported here, 29 of those were complete resections. I don't ever consider meningiomas that when they have dural adherence to be completely resected. And one was a glioblastoma, which was more for biopsy than resection. I had one case of mild numbness when we resected the L2 nerve root. I had a 3-level intramedullary ependymoma that had a permanent, a transient proprioceptive loss, but also a permanent dysesthesia. All other patients returned to work within 1 to 3 weeks, and there were no other neurologic deficits. We got 1 pseudomeningocele and 1 patient with dysesthesia. So that's my series, and that's my approach to intradural and intramedullary tumors of the spinal cord. I'd be happy to answer any questions.
Yeah. Great talk, Rick. We enjoyed it a lot. Yeah. What was the? Maybe I missed it, but what is the diameter of your tube?
That was an expandable tube. When it's not expanded, it is 18 millimeters, and it'll expand out to about 45 millimeters on the top to about 65 millimeters on the bottom.
Okay. The problem is with such cases, I'm also doing some intradural cases, is the stitching the dura at the end. It is more difficult than removing a tumor.
I absolutely agree.
What do you make to facilitate that?
Well, I designed some instruments for a company called Scanlon that are specifically to do this in a tube. Because the problem with a Castroviejo is that if you try and release the needle, the edges of the Castroviejo bump into the tube and you can't release it. So what I did was I took a upbiting pituitary, which we used to call a pea-pod. It's a small upbiting pituitary, and I modified it so that it would hold a needle. And therefore, the only thing that opens is right at the base of the, it's just the pituitary part that opens. So you don't run into problems with the tube. And because it's upbiting, it grasps the needle at the perfect angle to throw your stitch. Then I throw the stitch outside of the tube, and I have a knot pusher, like they have in general surgery for endoscopic surgery, that pushes it down into the tube. That makes it easier, but it's still hard.
Knot pusher is a very necessary part of instruments, I think, because the biggest difficulty is that.
I agree. It's the hardest part.
Yeah. We have one participant with us, Professor Ömer Hammat. who has great experience with tube-guided surgery. I think he's using Storz instruments. He wanna ask something. Can we make him unmute, Dr. Ömer Hammat? Yeah.
Yes, yes. Thank you, Dr. Zilili. Good morning, good afternoon, good evening for all of you. Congratulations, Dr. Zilili, for this wonderful meeting during this era of pandemic COVID. I have one comment and one question, please, if you allowed me. My comment, I've been using the easy go technique, the tubular endoscopic technique with the 18 or 16 millimeters, and through more than 20 years on more than 1,500 cases. And I find this is a quite versatile technique. It could deal with all types of disc, recurrent discs, epidural fragment, lateral, subligamentous, uniportal bilateral techniques, and etc. That's why my question, and this question for the panelists, please, do you find the full endoscopic technique has the same comparable results, or is it better than the tubular endoscopic techniques? And should we ask our genius to shift to the full endoscopic techniques rather than the endoscopic tubular part? And thank you, and wishing the best for all of you.
Yeah, Dr. Fessler can give an answer to that question.
Sure. You know, I evolved from doing full endoscopic techniques to doing most of my procedures with just loops, with 4x or 6x loops. And the reason for that was that our camera technologies were not very good. But with the new technologies I've seen coming out, I think we're going to evolve back into full endoscopic technique for many of our procedures, because the camera technologies now are getting good enough that the light is good and our ability to distinguish tissue planes is going to be just like a microscope. The imaging quality is just as good as a microscope. So I am now moving back into full endoscopic technique, and it's all because of the camera technology.
Okay. Dr. Kim, what do you think about that? Is it more advantageous tube-guided surgery, or full endoscopic technique is more advantageous? Please unmute.
Oh,
yeah,
yes. Okay. Thank you so much, Professor Richard Fessler, your good lecture. Maybe before time in my presentation, I gave some advantage of the full endoscopic decompression compared to the open surgery. There is some, first is more mobile and angled, and second is more deeper point is possible more clearly, and some fluid irrigation make a more clear view. But this advantage is still confirmed completely, because this it needs some more study, like some comparative study and some prospective study. But tubular surgery already confirmed so many advantages and some data, but endoscopic spine surgery still some processing of the study, and some doctors have some more skill. They talking like me, talking that there is some more advantage, but still don't know what is the result in the future.
Yeah. It's not solved yet, but probably it's more close to the conventional technique, the tube-guided surgery, than full endoscopy. Am I right?
Yes, and more angled and more deeper and more clear view.
Yeah. Although they have asked how do you close the dura, you answered that already. Do you use a glue to after closing the dura?
I do not, but I have no objection to using a glue, or something like a dural sealant. I have no objection to it, but I typically do not.
Yeah, there is one question. Is it possible to make a surgery for intradural AVMs with this technique?
It is possible, and if I've got what looks like a pretty easy AVM, then I will do that. But if it appears to be complicated, or if it expands over one level, then just to be safe, maybe I'm a coward, but I would do that open.
Yeah. What's added advantage over standard microsurgery?
The only advantage is just the structural part of it. Often with a microscope, you're working at arm's length away. For example, if your patient is in a sitting position and you're doing a cervical foraminotomy and discectomy, with an endoscope, you're very comfortable with the patient down and you're working with your arms in a comfortable position. With a microscope, you're working all the way out here, and no matter how good you are, your arms are going to get tired and your hands are going to shake. So it's mostly the physical portion of how you set up the patient and do the operation. Other than that, obviously the imaging with the microscope is wonderful.
Yeah. I want to ask Dr. Salim, he's also a endoscopic spine surgeon, about the intradural tumor resection. Is it possible under full endoscopy?
Hey,
Salim?
you ask me?
No, Dr. Salim from Istanbul is doing something. Salim?
Where is Salim?
Yeah, it is here, but his microphone is not open, I think. Sorry, we don't hear you. Okay, Henrik, what's comment on that?
Yes. No, I think, hello, Rich. Nice conference, nice presentation.
Nice to see you.
Really, for tumors, I think that the full endoscopic now is not enough, because as you see the presentation of Professor Fessler, you need a space, a very big space, to do the myelotomy and everything, and this is not possible. I think in some cases we can use a tubular and the technique, the minimal technique that Professor Fessler showed, but combined with the endoscope. We can use both, and I think is a good solution.
Yeah, thank you.